Dr. Khiabani joined us less than 2 years ago, where he did his general surgery residency at WashU, followed by a cardiac and thoracic surgery fellowship at WashU St. Louis as well, an outstanding institution, and has been a phenomenal contribution to our growing thoracic cardiac program here. I believe Dr. Khiabani is going to return back to WashU where he trained. He and Alina will be missed. Thank you for everything that you've done. I'm looking forward to your ground rounds. Thank you, Dr. Khiabani. Yeah.
So today I just wanted to talk about the basics of the finances for residents and some of the attendings. I mean, when I was a resident and a fellow, I kind of procrastinate when it came to the finances, so hopefully, the residents do better than what I did when I was a resident, and the attendings are far about, beyond where I am now in terms of, savings and making wealth. I got no disclosure. I'm also not a financial advisor, just what I learned with time. We're going to talk about some financial literacy, student loan management. How many of you have student loans currently and are paying? Oh, good. So some of you don't. That's great. Okay. Attendings, any of you are paying loans? You're still paying loans? I'm sorry, how old are you? So we're going to talk about that. We talk about the student loan management, financial advisors. Yes. I apologize for asking that. Insurance policies and basics of retirement accounts. Managing our finances essentially is our second job. We just have to be, as the CFO of our finances, and without the need of potentially a financial advisor, when we get to that in a second. Medical school teaches us the language of medicine. Residency teaches us how to practice medicine, but neither teaches us anything about business, personal finances, or investing. Personal finance and investing has a language just like medicine, and it can easily be learned. You can hire a financial advisor to teach you, to advise you every once in a while, but unfortunately that costs thousands of dollars, but with little effort on your end. Books are very inexpensive. It requires a lot of efforts. Blogs and internet forums are free, but there are hit and misses in terms of what you read. You don't have to believe everything you read, and plus, it takes, if you go on the wrong path, you can actually lose quite a bit of money. It does, however, requires a lot of effort, both financially and time-wise. You must spend time learning about finances and business. You really can't win this game if you don't learn the rules on your own. You can also, like I said, hire a professional to teach you. But again, everything they teach you or recommend, you just have to take it with a grain of salt. It's not their money that you put online. You must also spend some time to take care of your finances and business. You really cannot be 100% clinical, if you will, and be financially successful, in my opinion. How do you do it? How do you educate yourself? These are some of the recommended text books. You can see on the personal finance, investing, and behavioral finances, and physician-specific finances. I read 3 of these 4, except the Boglehead Guide to Investing. The rest are pretty good. There are also very good financial podcasts on your iPhone that are very easily accessible. Finance for Beginners is what I started when I was a fellow. And you should also put in a writing financial plan in place. If you have a spouse or family members, kind of get your financial plan together. Clark and I talk about this all the time. He has different goals than I do. So it's important to kind of have some threshold of what your spendings are, and we talk about that 50, 30, 20 rule, and we're going to talk about it, but sometimes you just have to deviate from that and based on your financial goal. Similar to your education, you also need to continue continuing financial education. Read at least one good financial book each year. Follow a good financial blog. I follow the White Coat Investment website. They have some good guidance both from coming from physicians as well as the CPAs that every once in a while they get invited to comment on things. There's also another good financial podcast that I started recently. It's called the Personal Finance Podcast by Andrew Gancola. It's also available for free on your iPhone that you can use. Frugal living, for medical students especially, every dollar you spend is really $2 to $3, if not more, once you pay it back. So spend carefully. This is obviously if you have to borrow money. How is it possible? How is that possible? There's the time value of money and also the effect of higher tax rate as an attending. So when I talk about this, every dollar costs you $2 to $3 at minimum. If you borrow $1,000 at the 7% to pay your rent as a first-year medical student, if you let the interest pile up for 4 years of school, 3 years of residency, and 3 years of fellowship, that's already 10 years. Then if you pay it back based on the current income-based repayment plans of 20 years to 25 years, by the time 30 years have passed, that $1,000 becomes $7,600. Now, if you pay it off within 5 years of fellowship graduation, that comes down to that $3 that I mentioned, $2,700. The effect of higher tax rate. So if you borrow the money, so this is triple after tax money. You borrow it after tax, you spend it after tax, and you have to pay it back after tax. So you're on a lower tax bracket right now as a medical student or resident, but you have to be on a higher tax bracket when you're paying it off as an attending, Dr. Salter. At 45% margin tax rate, you would have to earn $13,840 to pay off that $7,600 that I mentioned, assuming you go that 20 years of payoff. So what should you do then? Be a poor medical student, have a roommate. So easiest time to be poor in your life is during your medical school time. Everyone around you know you are poor. Limit how much you eat out, free food at the hospital, right? You earn what you drive. Reliable transportation in America is actually cost less than $5,000, Get a roommate if single. And then, one of the things I read, it says send the partner to work if not single. I'm not sure if I would tell that to my wife, but it was something that's recommended commonly. How do you minimize debt? Spend less, use your saving and family help first. Don't take out debt until you really have to. Medical school loans aren't subsidized. As many of you know, with the current administration, we are also coming down on the limiting the amount that you can borrow. So that has good and bad. But with the rising tuitions for medical school, I think we will run into some problems with that. So don't borrow a year worth of money in August. If you do, everything piles up for the whole 12 months, even though your tuition due, every quarter or every semester. So you can actually break it down every quarter or every, FAFSA can do the distribution for you based on what you ask them to do. Consider working summer work before your second year of medical school during MS4. If you must borrow, get the best terms. Max out on the federal loans before private loans, and we'll talk about that briefly in a little bit. Consider home equity, family loans, or 0% credit cards. Considering school for your medical school as well as the residency costs. So cost of attending a medical school is obviously highly variable. What's the cost for Creighton, if you don't mind me asking? 70 grand. Tuition? All right. I think we can send Dr. out of 5. Maybe we can talk to the dean to get it lower. So in-state versus private loan, private school. So Creighton considers the private school versus in-state or public medical school. My medical school cost $45,000 when I started. It went to $60,000 when I graduated 4 years later. And then, as you all know, fourth year medical school, you really don't do much. You're actually working, but you're paying the highest amount, plus the interviews, plus the all those away rotations that you were planning on doing. Don't forget the cost of living too. Obviously living in Omaha is cheaper, so it's an excellent choice to come to Omaha. On the other hand, if you go to the coast, 3 or 4 times higher, if not more. Location is the primary financial factor for residency. Rent can vary by a lot. A married couple with several kids and a stay-home spouse will feel very poor in many locations. Resident salary varies, but not by a lot. You know, here maybe 70,000, in California maybe 85,000 at most. So pick your residency choices. Obviously, I said fit and quality of education matter. In my opinion, that comes first. Second comes the cost of living and everything else. And consider moonlighting opportunity. Obviously, this is something you need to talk to your program. You know, when I was a resident and went to the lab, I was allowed to do moonlighting. We were not allowed to moonlight during our clinical years. So it's something that, you know, Dr. Arafai and Dr. Patel can help you if it is something that you guys are interested in doing. And you make quite a bit of money, you know, even if you moonlight here in the ICU when you're in the lab or other surrounding hospital. Are they allowed to moonlight? Or do we have a policy for moonlighting? During your clinical years, right? But we have a lab resident the first year. Are they allowed? Yeah, good. So that's one opportunity I really highly consider. When you find yourself in a hole, stop digging. Don't borrow more money in residency, not for living expenses, not for cars, and probably not even for a home. Debt limits your options. So student loans, we talked about the increasing rise of tuition. So mean debt in 1999 was about 122,000. In 2018 was about 250,000 for DOs, about 200K for MDs. And then half of those doctors back in 2018 had more debt than what's reported, what's the average. And that's after 2020, that has come up to about 300 to 450,000 is becoming more common. And government won't refinance even after the rates fall. So monthly payment, let's say you have a $400,000 loan at 7.5% is about $4,900 per month for a 10-year repayment plan. If your gross income is $210,000 after taxes, you're at $160,000. $4,900 per month is about 37% of your net income, and it's only getting worse. Private loans. So if you max out your federal loans as a medical student, and then you start getting private loans. So private loans have a lot of them obviously you still can repay after your 6 months, but they have a higher rates than federal usually. So my recommendation is pay them off first, refinance them right away, and then after you graduate. The reason for that, the refinancing the private loans, you always, almost always, you went from no salary to some salary, $80,000, or you went from a resident to an attending, a huge jump in the salary. Your refinance rates are a lot less when it comes to your interest rate. So you can refinance, and you can continue to refinance every time. A lot of those loans, and a lot of those companies, which I have listed, I'll list in a little bit, for refinancing, they actually have zero initiation fee. So you essentially accumulate all your loans and then refinance right away and start making monthly payments. So you drop the 7.5% private loan interest rate to 4%, depending on your credit score and your income. And best terms are usually 5-year variable loans. This is best if you do it, especially when you're a faculty. If you pay it off within the first 5 years, you're in excellent shape. Federal loan repayment, we have the income contingency, and these are all income-driven payment plans, pay, repay. And I'll talk to some of about this. The pay is the best. It's harder to get, but if you have a federal loan, you need to become or hire an expert in these loans. There are so many programs. Every administration comes in and messes around with certain terms of it. But the one thing that they haven't been able to get rid of is the public service loan forgiveness plan. It started by George W. Bush, and Obama tried to cap it at $50,000 forgiveness, $53,000 forgiveness. Fortunately, he was unsuccessful. So right now, all the loans you have, if you are in public, and then Trump tried to do it as well, but it was also unsuccessful. So everybody who is enrolled in the public service loan forgiveness plan, they get grandfathered into it. And then after 120 payments, all your loans will be wiped out, tax-free. We'll talk about it. And even with the current administration, we had a few people who got forgiven. One of my buddy who is a neuroradiologist just got his forgiven about 6 months ago under this administration. I think Dr. Clark's loan got cleared out during Biden's administration. They are behind by about a year to process the applications, but once you hit that 120 payments, you can actually put everything on deferment. You don't have to make a zero payment as long as they have it. So this is the income-based repayment. You can see based on number of people in the household and the discretionary income, depending on what plan they put you on, repay, pay IBR, which no longer exists, and income contingency repayment. You can see the payments. Payments have nothing to do with the interest rates. Payment also has nothing, almost had nothing to do with the debt burden. If you have a debt, your income is certain, you pay this much among all of you. Okay, they are solely based on your income and number of people in your household. So public service loan forgiveness, there's really only two questions that they ask you. Are you working for full-time for a 501c entity, which Creighton is one of them, CHI is one of them, or are you working for a government employer such as VA? Did you make a lot of small IDR or income-driven repayment plans during residency or /fellowship? When you graduate from medical school, people say, oh, you can defer it, your loan payment until after you finish your residency. Don't do it. Because, and there's a misconception that if you're a resident, your payments don't count. That's also wrong. Every payment you make, the moment you start making money, every payment you make counts. It's better to pay it off during your residency. For surgeons, you know, that's one incentive for a lot of medical students to go surgery. Your residency is 5 to 7 years, you know? So that's more than half of that 10 years that you have to pay payments, you are making low salary. So you get a lot more forgiveness at the end. And then did you make a lot of payments? If so, I had a list of those income-driven repayment plans that if you're part of those, all those payments count as long as you make them monthly on time. But also, if the answer to those is yes, you're qualified for a public service loan payment, but save up some PSLF side fund, and I'll talk to you about that, what that means. Now, if you own more than 2.5 times of your gross income, you should consider pay or repay forgiveness because it's faster to pay it off under those plans. Those are either 20 or 25-year plan, and get some professional advice. If not, refinance and pay them off using the refinancing, which you convert the federal loan to a private loan. So this public service loan forgiveness, as long as you are part of this, one other thing about this. So SAVE plan. So if you all remember SAVE plan, who remembers SAVE plan? Good. So Biden administration came up right after COVID with the SAVE plan for student loans. A lot of us got excited, myself included, because it dropped your payment by about half. So you go from $300 payments as a resident, you drop it to about $150. It only worked for about 2 months. Then the government changed to Mr. Trump, and he put a cap on that. So if you are on the SAVE plan, you went to Washington multiple times, and the current administration won. So the SAVE plan, if you are currently in it, get out of it. Go ahead. Good. But they've been talking about it for the past 6-7 months. So the sooner you get out, you start making those payments, the faster you contribute towards that 120 payments. Why does it matter? Because currently we have that buyback plan, buyback option. Who's aware of the buyback option? Good. So the buyback option, they are about 14 months behind on calculating the payments you made or you may not made under the SAVE plan, under Biden administration. So the idea is, even though your payment were zero during COVID or after COVID, that your payments of that zero counts towards 120 payments, but we don't know yet, right? So there's a lot of uncertainty with that, but the moment you start making payments, those 120 would count. Now, like I said, you make 120 one-time payment. This could be a $50 payment as a first-year resident to $120 or $250 as a senior resident, to up to about $2,900 or $3,000 based on your income as a faculty. But once you reach the 120 payments, all of that loan is forgiven. Usually it takes about 6 to 8 months to apply. But like I said, you can, the moment you hit the 120 months, you can put everything else on deferment and wait for the government to make the decision on your forgiveness. And all of that, unlike any other plan that we currently have. So pay, repay, all of those are tax deductible, meaning you pay tax the moment you get forgiven. But this is the only one that the moment you get approved, all of that is distributed among all of us. So you pay zero tax on that. And most residence and fellowship, like I said, is 501c3. And most academic places are 501c as well. So why PSLF works is lower payment during training, amount forgiven equal differences between residency payments and regular payments, and amount forgiven equals about what you owned as a medical student graduation. Meaning all you pay in that 10 years is probably the interest that accumulates over these 10 years. PSLF usually is the best option if you qualify. Why did I say you need to save up some PSLF side fund? Because like I said, legislation, every government that came to this, every 4 years, they go to the Washington and they try to get rid of this program, and so far they have been unsuccessful. Also, career risk. Let's say 2-3 years you work for a place that is 501(c)(3), but then you decide to go to private practice. Private practice is unfortunately not qualified for public service loan repayment. So it's better to have some side funds to pay it off if you decide to make that kind of move. The other options are, like I said, a student loan refinancing. You must qualify. It's based on your credit. You may not be offered the same rate and terms as your other colleagues, and highly dependent on debt level, income level, and credit. Typical rates, like I said, the best one is the variable 5-year. So fixed 5-year rate, after that it jumps, but you can always refinance. So you convert your 7% loan to 2 to 4% loan. And you can typically get those once you are attending contract in hand. Or if you go from medical student to a resident and you have a private loan, you can do the refinancing on that. Here are some of those companies who does the refinancing options for you. Sophie is what I use for my wife's loan, and I'm very happy with that. So how do you pay off your student loans quickly? Send a large check every month to the lender. Easiest to do it right away, right out of residency before your lifestyle changes. Live like a resident throughout the residency and the first couple of years of an attending. That's the secret of being a wealthy physician. If you run the numbers, your average resident salary, let's say 60 to 80,000. Your salary as an attending is 320,000. Once you pay off the taxes, of the 90,000, your living expenses of 60,000, you're left with the 170,000 cash that you can pay off your loans, save up for a down payment for your house, or max out the retirement account. How long will it take you if you have that how long will it take you to pay off that $400,000 loan if you live off that $170,000? Obviously, less than 1 year if you have debt of $100,000, and then less than 3 years if you have $400,000 debt. Live like a resident. That's the secret to physician wealth. By living like a resident, that's something I'm writing here, but I wish I would have followed this, what I'm telling you today. By living like a resident for 2 to 5 years, you can pay off your loans, save up down payment for your dream home, and build a greater starter nest egg. Then you can dial it back after this 5 years to saving rate of about 20% of your gross income, that 50-30-20% rule. So 50% is your necessary expenses, your needs. 30% is things you want, and 20% is your saving and debt payment. Now, I wrote here, fighting the burning desire to buy a house. It's everybody's dream is to buy a house, especially if you have doubts on the location and a job. Renting is not throwing money away. It's exchanging money for housing. Property taxes, realtor fees, mortgage interest is all throwing money away too, right? So rent payments are supposed to be more than mortgage payments due to other costs of home ownership. Selling the house for more than what you bought it doesn't necessarily mean you made money on it. Obviously, transaction costs on selling a house matters. You actually make money. You can see here, if about half of the time you make money if you own the home for 5 years. That's assuming everything's good. About 1/3 of the time if you own it less than 3 years. So when I was a resident, I bought a house as a PGY2, sold it when I was a PGY8. Clearly followed the rule, did not lose money. Renting also allows you to focus on training. Mortgage interest isn't deductible for most residents, and residency graduation is a difficult time to sell a home. Now, with that, we switch to financial advisor. So here, William Bernstein is a neurologist, but also a financial advisor. He says you are engaged in a life and death struggle with the financial services industry. If you act on the assumption that every broker, insurance salesman, and financial advisor you encounter is a hardened criminal, you will do just fine. How many of you work with a financial advisor or being contacted with one? What's the first thing they want to sell you? Whole life insurance, right? Yeah. Good. So commitment to a profession is important. More experience than you. I don't like it when they ask for commission on your investment. So work with some sort of fee only. Fiduciary duty, knowledge of the investment literature, and experience with physician-specific issues such as taxes, student loan issues, and retirement account. The cost of financial advisor, if you think about you're just paying 2% of your portfolio each year to these fees, commissions, and expenses, how much less would you end up with? So in 30-year, 8% pre-fee return, saving $50,000 a year, you go from $6.1 million investment to $4.2 million. So is it really worth the $2 million that you lose in that 30 years to have an advisor? That's debatable. 5+ years of your gross salary, and that's about $80,000 per year in your retirement plan that you'll be losing in that 30 years if you do the financial advisor. There are different models for financial advisors. Like I said, some of them work based on commission. Some of them work based on your assets under their management fee. So, and then some of them charge you with hourly rate or annual retaining fee. A fair price is a 4-digit amount per year. I think when I became a faculty here, I looked hard to find a financial advisor. I found one, and it charged me a set rate of $2,500. So, but I'm also not asking for a lot of guidance. We talk about the insurance. That's the first thing they want to sell. So insurance against financial catastrophe. So these are high deductible, low premium. If you self-injure, do health insurance, term life insurance. We have a whole life insurance. We have disability insurance, umbrella policies, and malpractice insurance. Don't mix up the insurances and investments. You really don't need a whole life insurance, especially as a resident or the first few years as a faculty. I really don't understand the whole life insurance. Who has the whole life insurance? Good. So health insurance, obviously you need a health insurance. Disability insurance. How many of the residents don't have disability insurance? Just 2, 3? Okay. Hopefully I can convince you to get one, because this is the healthiest you ever be. This is the youngest you ever be. This is the lowest income you ever be, right? Because a lot of the disability insurance, as long as you have a correct riders on it, such as COLA is a cost adjustment, such as a physician-owned occupation policy. That is, if you are a surgeon or a surgical oncologist, and God forbid you become disabled, you could be a critical care ICU attending, you still get paid because you cannot do your job. Okay. And then you can also, every disability insurance you get, doesn't matter the age, you have to get medical clearance. You know, they get a bunch of labs and physical exam. And like I said, this is the healthiest you're ever gonna be. So if you actually do one now, you can increase your coverage over the next 2-3 years when you become a faculty with no medical exam at the current rate. Liability insurance, we have malpractice professional liability insurance. A lot of times your employer provides that, and then umbrella policy is what usually you get. You know, typically $2-3 million coverage, and then term life insurance. This is, you know, typically people get $2-3 million life insurance for a 30-year level, and then homeowner and renters insurance. So whole life insurance, on the other hand, is a lifelong insurance policy with a cash value you can borrow against. It costs about 8 to 20 times the cost of a term life insurance for the same death benefit. It has a cash value that has low return and takes 5 to 15 years to break even, meaning you have to pay that high premium in order to get it out at the end with probably about 3 to 4% return, which doesn't make sense. It has high commission and a product designed to be sold, not bought. So typically when you get approached by a financial advisor, really the first thing they talk about is the whole life insurance. Maybe the second thing is the disability insurance. And then 75% of the physician buyers regret their purchase. And if you actually, after 2 years, decide that you don't want the whole life insurance, you lose whatever you paid for that 2-3 months, for that 2-3 years. Long-term care insurance, you know, this is something some of the patients, I didn't actually know about this until encounter a few of the patients and start reading on this on White Coat Investment. So is poor and single people can spend down to Medicaid levels. Millionaires can self-insure, and married middle class should consider it. Someone who makes you know, about $1 million a year. Or have $1 million as a saving account for retirement. Not quite ready for prime time. Companies usually go out of business, premiums raised, and no longer affordable. Now, what are the greatest tax breaks, both for residents and faculty? Again, like I said, retirement accounts, this is really your second job to, to manage your finances. Read your plan document, understand all tax advantage accounts available to you and how they work. You know, in a private practice model, an academic model, or something hybrid, usually they have the 401k or profit sharing plan. I know Common Spirit has both of them offered to you. And then usually if you are hired by a university, they usually have a 403B or 457B as a plan. Understand all the tax advantage accounts available to you and how they work. You know, if you're self-employed, you can create your individual 401k. If you're everybody else, you can also add backdoor Roth IRA and HSA and 529 for your future kids or current kids. Why does it matter if you do a tax deferred retirement account? You can see the diagram on the right. If you pay the taxes later, you can see your total accumulation is a lot higher than if you pay the taxes now. So your lower taxes equal higher return. So this is, and we're going to talk about it. I think I have a diagram of that I'll show you. As a resident, it's actually better if you pay the taxes now, whereas once you become a faculty, it's better if you do a tax deferred for saving. So why a 401k is awesome? You have an upfront tax break at 28 to 37%. You have a tax protected growth. You have asset protection, and it helps you with the easier estate planning if you start doing so. 401k withdrawals will fill the tax bracket at the withdrawal time. So when you are retired, you clearly are not making that $350,000 to $500,000 salary. Your salary actually, if you wait a year after you retired, your salary is zero. So your total income that you pay taxes, you know, whatever you withdraw. Let's say you start withdrawing at $100,000 per year, that's your salary, and that's how much you would pay taxes, as opposed to the $400,000. So this is the retirement account, assuming married couple, no other taxable income, and the standard deduction. So you can see, let's say you have, this is why you would want to use the 401k during your peak earning time. So if you withdraw once you're retired, you're obviously hanging out with a 12% maximum tax bracket if you withdraw $100,000. Whereas if you are in a $500,000 income, you're at the 35% tax bracket. So you can see if you do the tax deferred withdrawal after you retire, you have significant tax benefit when it comes to that. You can pull up more than up to $360,000 per year at the marginal rate no higher than 24%, which is here. Your effective rate would be 19%. On $100,000, your effective rate is 8%, as opposed to that 37% where you do tax deferred. For most doctors, even with the Social Security, your effective tax rate is likely to be about 20% in retirement, as opposed to 37%, like I said earlier. And then in 2010, the Roth conversion became legal. Before then, high earners couldn't deduct a traditional IRA contribution and could not contribute directly to a Roth IRA and convert tax-deferred money to a Roth IRA, but you currently can. And there's a limitation on that. So you can contribute, the way the backdoor Roth IRA is, it's a little bit harder with the income for residents, but once you become a faculty, you contribute whatever the maximum is to a traditional IRA, and then you convert it back from the traditional IRA to the Roth IRA. Usually takes about 14, 15 days for the whole transaction to go through. And then be aware of the pro rata rule, which is you have to be careful when you convert the pre-tax IRA to post-tax Roth IRA. If you do, you just have to pay the taxes on that amount that you convert. And then fill out your taxes correctly. You can do the same thing for the backdoor Roth IRA for your spouse if they are not working. Current contribution is $7,500 for each of you each year, and $8,600 if you are 50 plus. And then health saving accounts, use it wisely. Must have a high deductible health plan in order to qualify to put money away into that account. These are the tax deduction for contribution, tax deduction for the growth, or tax protected for the growth, and tax-free withdrawal if you use it for healthcare. So triple negative. You pay it before tax, you pay and you withdraw also before tax. I mean, you don't pay taxes when you do withdraw. And $4,400 for single, and $8,700 if you're married for 2024. And then if you're 50 years or older, you pay $1,000 catch-up. It's usually the first account to contribute each year, and then after age 65, you can spend it on anything you want, penalty-free. And withdrawals need not to be in the same year as the spending. So there are some health saving accounts that if you contribute to it and you don't use that money during that calendar year, you will lose that money. However, with the HSA, you can keep enrolling into the future. And that's all I got. I think, other topics to consider talking is the estate planning, asset protection, and, contract evaluation, when you guys are going for the first job. Any question?
Thank you, Dr. Khiabani, for an interesting topic. I think it's important for all of us to know about finances. Questions for Dr. Khiabani from Zoom or in person? Let me, I have a comment and a question. So the first one is I heard that medical schools don't teach us, which lead me to believe medical schools are not designed. They're designed to make us physicians, compassionate physicians, serve community. I don't think medical schools are designed to teach future doctors how to take care of their finances. I think there's unnecessary emphasis on the role of medical schools nowadays, the more I think about it. A book that really helped me understand finance is The Psychology of Money, which I read a couple of years ago, which makes you think about how you were raised and you think about spending. A fair amount of it is habitual and dopamine related.
Mhm.
And I think if you look at high earners, including surgeons, some habits are picked up either from role modeling, from mentor about high spending unnecessarily. So
Absolutely.
what are your thoughts? I didn't see that in your talk. One of the early lessons for me in DC is buying a fancy car is a bad idea. The streets are
Yeah.
terrible. The beneficiary of a nice car in Washington D.C. is a parking lot in your where you work,
Yeah.
and that's an early lesson for me that I've moved away from fancy cars.
Yeah.
But can you speak to the psychology of spending and why what drives it? Because some high earners, including surgeons,
Yeah.
thrive on that as well,
Absolutely.
and it feeds into the narcissism of a surgical personality as well.
Absolutely. So, no, I agree with that. I think part of it is how you were raised, how you lived to become 40 years old later. If you come from a family that had money around, and you spend left and right, then you don't consider it, and you buy. Uh, like you said, you look around to your mentors and how they spend their money. You want to catch up with them, especially the first 2 years when you come out of a residency and fellowship. I didn't buy a fancy car until about a year and a half, 2 years after I became a faculty. I drove the same car for 6, 7 years during my fellowship and being a faculty. I think the other part is, like I said, you go if you can practice, and also I think part of the one of the contributing factors is how your spouse and your kids want to live, right? I think that's something that I really appreciate. They struggled quite a bit during your training. They didn't see you. When I was a fellow, my wife barely saw me. 2 hours a day on average. So when her expectations for me, when I became a faculty, and obviously the money was no longer an issue, was to satisfy some of those needs. And so, yeah, I mean, it's important to, if you can follow that 50-30-20 rule, you'll be all right. But it really depends. I mean, I have surgeons who make close to $2 million a year, and they still drive a 20-year-old car. So it really depends. I don't know who's doing the right way. I don't know.
Thank you. Questions, Dr. Barron?
Hey, thanks, Dr. Khiabani. One thing I'm wondering if you can speak to would be, as you become an attending, have more disposable income, or even just as you age, just in general, the evaluating when someone comes to you with investment opportunities, like individual investment opportunities, either in businesses or funds, or that's something I'm a little bit older than some residents. That's something I've even come across personally, just how you go about evaluating that, how you go about kind of navigating those situations.
Yeah, good question. So unfortunately, mutual funds is so hard to predict which direction they go. So I grew up in Iran. I came to Chicago, and I lived with my mom's uncle. One of the advice he gave me when I was 17, he said, "Hey, I'm not a financial advisor, but I follow what Warren Buffett do." So that advice stick to me now, 20 years later. So I literally, follow him all the time and figure out the moves he does. What he sells, what he sells. And when my advisor tells me, "Oh, I think this advice, if you do this, it's beneficial," I kind of look at his portfolio and see. So if you find someone who's successful and you kind of follow them, again, that doesn't mean they're 100% right, but they have that hunch, that the financial hunch, that if you follow it, you'll be successful. But also, I wouldn't invest too much, because those are a lot riskier than your 401k and your normal Fidelity accounts.
Thank you. Questions?
Hey, this is Dr. Akar on Zoom. Can you hear me okay?
Yes,
Yeah.
go ahead, Dr. Akar.
Yeah, I think that was a great talk on a very important topic. I was going to just throw in a couple of comments. You talked about debt, and I've encountered situations where some of my residents have come to me and said, you know what, it's been a hard time, and I've maxed out my credit cards. I have several credit cards all maxed out. I'm trying to figure out what to do next. My advice was clear and simple. Visit a bank and refinance all your credit card loans, which usually have interest rates in the 20% range, down to a personal loan. Bankers like doctors, because they consider us reliable payers, and you can refinance at prime rate +1 and save a ton of money on interest while you work down that debt. And I entirely agree with you that working down debt should be your primary concern rather than increasing your lifestyle after residency. But when you do work down debt, or even before you're completely out of debt, you need to think about investing, and that's another quagmire. There's the old saying about doctors that I think applies to financial accountants and lawyers and everybody else. If you ask three of them the same question, you're likely to get three different answers. So that's why you really need to learn to understand investments, because nobody cares about the performance of your portfolio as much as you do. And there are ways to do that. If you like to watch TV, watch one of the financial channels. I mean, CNBC is my favorite. Anything that's important in the news is going to show up there, and you can see trends. The other key thing is to learn to evaluate risk and consider putting your money into different buckets. Your base should be a safe investment strategy, which is not going to give you tremendous returns, but you can save a little bit back and put it into a high risk bucket that will give you outsized returns if you can afford to lose that money. And so probably the best performance is not to accept just one strategy and follow it, but to have a couple of strategies and balance them to kind of get the best of both worlds. Safe, steady, predictable, possibly not too high returns, plus a little bit of side money that you can put into high risk. So that's my advice.
Thank you, Dr. Akar.
No, I agree. And I think there is a lot of attraction to this personal finance for physician. We have it from American College of Surgeons. Last July, they came up with their first webinar on this. WAMC just came up, I think last October, with their first, have you guys heard of this first financial info resources, service and tools website that primarily focuses on personal finance for physicians. So, you're right, Dr. Arafai, that, medical school is not supposed to teach you that. And you clearly don't have time to learn that about in residency. But the moment you become a faculty, all of a sudden your job becomes double. You can't be really 100% clinical. Because on the finance side of the hospital, all of a sudden, medical school doesn't teach you about billing. Then all of a sudden you're expected to bill at a 99% correct rate on knowing the CPT code and knowing all those things that you get zero training during your medical school residency and fellowship. So I don't know.
So I want to go back to the comments. I think building wealth and spending and saving is more habitual and not through medical training. I really recommend the psychology of money. I don't think schools are designed for that. I think onboarding in a new job as a new attending, there are opportunities to learn. I also want to go back to a comment I just heard from you about we don't see our families who are in training. And it just brought me back to a comment my daughter, when our family are having the conversation, do we leave DC to move to Omaha, from a chief section to a chair position? And it was a crucial conversation that we had with the family about do we move or not move and so forth. And this is what my daughter now is going to go to high school next year. Then she was 11, very wise, mature beyond her years. And these are the reasons why we're considering the move. And one of the conversations that she said, I want more of your time. I don't want more of money. And so that was very important and resonated with me. And I broke the rule that I have is I don't like to live where I work, because I end up staying in the hospital. And here I am, I live 7 minutes away from work, which is something I try to avoid. It turned out to be the best decision I made in terms of living close to the hospital. So I think throwing money to make up for being busy may not make up for that as well. So I'm just listening to those comments, and I I couldn't help not resonate with that conversation that I had with my family. Other questions?
I was just going to make some comments. Awesome talk. Took away my idea for grand rounds because I like this stuff too. Yeah, I can't emphasize enough how important it is to get started early. Compounding interest or compounding gains is how you accumulate wealth. And so the earlier you start, the better. And personal finance for dummy, I've recommended that to people for a really long time. It's got a lot of common sense, easy to understand ideas about how to invest in, different investments and, buying a home and all the stuff that kind of went into, it goes more in depth. And that's really important. I always say too, a credit card should be a convenience card and not a credit card. It's not a loan. You should pay it off every month. That's a way to prevent paying a lot of money and interest as well. So awesome talk. Thanks.
Thank you.
Dr. Griffin. Thank you, Dr. Harvey.
So from the show of hands, it looks like most of you have disability insurance. Does Creighton provide it to you, or do you guys seek it out yourselves? Okay, good. Just because, so
Okay.
it's also, you do all have it. Because one of the things is so I had several residents during my training who actually needed their disability insurance. I had an intern last year who developed MS. There was a resident, one of my co-residents, who was an anesthesiologist who unfortunately had to go to rehab and now is no longer a doctor, and a few other ones. So it does happen. You do have to have it. One of the unfortunate things is that you need to, if you're one of the female trainees, you get gender neutral pricing while you are a trainee. So you need to max out your coverage while you're still right before you graduate, because that price goes up significantly. When you turn 30, your price goes up. If you have a parent who died of non-accidental causes before the age of 50 or 60, excuse me, it also costs more. So those are all things that you have to think about. And you can increase your coverage after your PGY2 year. So all of those are things that you have to keep revisiting. Just because you bought it when you were an intern, you need to revisit it every year to see if your coverage, you have more kids, you have your home life changes, all things that you have to consider.
Thank you, Dr. Griffin. That's your point, Dr. Khiabani. It's incredibly important to have a disability insurance. And we all know folks who got injured, skiing injury. I know a gastroenterologist who injured himself in a skiing injury and unable to perform an endoscopy. A surgeon who slipped and fell in an icy day as well and couldn't operate after that. I mean, these things happen. You don't know when they happen. So to your point, Dr. Griffin, thank you.
So there was a survey in 2022. What do you guys think is the rate of disability among physicians the first 20 years of their practice? Yeah. So that's what, 12 to 25%, right? That's a lot. That's 1 every 4 physicians get disabled within within the first 20 years of practice. And I think that's important because, again, like I said, if you have to Dr. Griffin's point, there are 2 types of disability insurance. There's one that your job provides, and unfortunately, that doesn't cover your own occupation. That covers you as a doctor. So, i.e., you have to be brain dead not to be a doctor, right? But the one that you get privately, Mass Mutual or whatever, that's physician own occupation. So your own occupation rider is what matters.
Specialty specific is the word.
Especially, yeah.
Specialty
and if you're a
specific.
surgical resident, you tell them, hey, I want to become surgical oncologist. They put it in. As long as you show them that you're on a path of become a surgical oncologist, you are a surgical oncologist. And if you become disabled, you shift as a resident, you can become a, ICU doctor.
We have time for one more question or comment. Dr.
This is just a
Kova,
comment.
we'll close with you. Yeah.
We got to talk similar to this a couple of times during residency. That accounting mentioned the Roth IRA is probably the most important thing you can do at this point if you don't have one. You're basically, most of us start out like 10 years behind our peers, where if they take a job right out of college, you have an employer that they're contributing to a 401k and then their employer's matching it. And all the time you're in medical school and training. That Roth IRA is probably the most important retirement account because you're not taxed during retirement when you take the money out. And that's why they limit how much you can put in. And most of us, when we come in attending, you won't be able to put money in the Roth IRA anymore unless you do that Roth conversion. But I would encourage anybody, if you don't have an IRA to maybe open one and just put whatever money you have
Yeah.
left over in there now. Unfortunately, I did this like 2 months before COVID hit, and like I put like $5,000 in there that I had and lost like 30% right away, but it'll go up eventually.
And like AJ say, WCI or White Coat Investment has a lot. I mean, a lot of my information is from there, you know, so they have a lot of information there that you can just follow them.